Hello and welcome to this lecture on acute appendicitis. This video is a part of our series on surgical emergencies. My name is Dr. Wahab Fazal and now let us get into it. So we're going to start this lecture with a case, then we're going to talk about the pathophysiology of acute appendicitis and how it happens, the clinical features which include the signs and the symptoms of acute appendicitis, the diagnosis, so how do you make the diagnosis of acute appendicitis, and then the management, and I'm going to tell you the step-by-step management. So starting with the case. So a 26-year-old male is brought to the emergency department with a complaint of progressive right lower quadrant pain for the past hour. He says that the pain had progressed from a dull, vague sensation around the umbilicus, the belly button, to a more specific location around the right lower quadrant of the abdomen. Temperature is around 101 Fahrenheit, so he's running a fever. Pulse is 100, so it's on the higher side. And BP is 130 by 80, that's around normal for someone in pain. Pulse may also be normal for someone in pain. What is the most appropriate next step in management? Now, let us talk about the pathophysiology of acute appendicitis before we understand its management later on. So, what is appendicitis? First of all, what is appendix? Appendix is a vestigial organ, meaning we think that somehow during the evolution process, this thing became useless, this organ became useless. Now it's a vestigial organ. Inflammation of this worm-like organ, sometimes called the vermiform appendix, is called acute appendicitis. This worm-like organ, inflammation, appendicitis. How does it happen? So how does this inflammation even happen? It happens with luminal obstruction. What do we mean by luminal obstruction? Just think of a pipe. Inside the hollow thing through which the water runs is its lumen. So when you get blockage of this lumen, why does this blockage happen of the appendix? Well, it happens because of fecalith, meaning feces that get deposited in it and solidify, they become fecalith, and this is particularly in older people. In older people, appendicitis is usually due to fecalith. In younger people, this is due to lymphoid hyperplasia. What does that mean? That means due to the lymph cells and their inflammation and their hyperplasia, meaning they divide in number and then they block the lumen of this organ, particularly in pediatric population. And that's how appendix happens in pediatric population. And what does that lead to? That leads to the distension. That leads to a buildup of pressure inside this organ, which causes what? Which causes the veins to swell up. What does that lead to? When the veins are swelling up, that means they're not carrying away the blood that is coming in through the arteries. What does that lead to? That leads to decreased blood circulation in this vermiform organ. The blood that is coming in is not going out. That leads to decreased blood circulation, leading to bacterial invasion and inflammation. Whenever blood is not coming to an organ, you're being more susceptible to bacterial invasion and thus inflammation. So what are the clinical features of appendicitis? So starting with the symptoms, you have nausea, vomiting. Of course, there's an inflammation, there's active inflammation inside your body. You'll get nausea, vomiting, you'll get fever, you'll get dull, diffuse pain around the umbilicus, dull, diffuse pain. Why is the fever happening? Because there's inflammation, so you might get release of interleukins like IL-1 that cause fever, and then dull, diffuse pain around the umbilicus. Why is it dull? Why is it diffuse? Because this is due to the visceral peritoneum around the T10 area, which is the dermatome which relates to the umbilicus, This is sometimes asked in your exams and vivas. Why is there dull, diffuse pain? And this happens initially. This happens earlier when you just have inflammation of the visceral peritoneum, which is innervated by the dermatome T10, which is why it causes that referred pain to the umbilicus. And then after a while, later on, you get localized right lower quadrant. So right lower quadrant pain, particularly due to the parietal peritoneum, particularly due to the inflammation, irritation of the parietal peritoneum. What are the signs? What are the signs of acute appendicitis? Well, you get right lower quadrant tenderness. Remember, so the patient says, I have pain. When you check, that's tenderness. Tenderness is found on exam. So again, you'll have right lower quadrant tenderness. This is called McBurney's point. What is the McBurney's point? McBurney's point, if you just press your finger on your pelvis right now, on the anterior, meaning on the front side of it, you'll feel a spine, you'll feel a spinous process, you'll feel this pointy thing. That is the anterior superior iliac spine. From that to the belly button, right? Take 1/3 the distance from this ACES, the anterior superior iliac spine, the spinous process on the front of your pelvis. Take 1/3 the distance. This is McBurney's point. This is exactly where you'll have the right lower quadrant tenderness. This is one of the signs. Then rebound tenderness. What do we mean by rebound tenderness? Well, that happens due to receptors in the parietal peritoneum. Basically, you press in, and whenever you leave, as soon as you leave, due to the irritation of the parietal peritoneum, the patient will experience pain. That is rebound tenderness. Basically, as soon as you leave and the abdomen comes back to its place, the parietal peritoneum gets irritated and you get rebound tenderness exactly at this point as well. Now let's talk about the very, very famous psoassign. What is the psoassign? Remember, the psoassign does not just tell us whether the patient has appendicitis or not. It also tells us where the appendix is lying. So let's look at it. So you ask the patient to turn on their left side. This is the right side. And from the right hip joint, you ask them, or you do it, you passively extend their right leg. You extend their right leg at the hip joint. So you extend it, you pull it backwards. Remember, look at this arrow, you're pulling it backwards. And what does that cause? That causes the patient pain. This does not only signify that the patient might have appendicitis, it tells you something else as well. It tells you the possible position of the appendix, And what could that be? That means that this appendix is now attached. This appendix is now attached to the iliopsoas muscle. And remember, the iliopsoas muscle is behind the cecum. This is a picture from the front, but if we look at it from laterally, you can understand that these are, let's say, the patient's ribs. This is the iliopsoas muscle that is coming down and attaching to the patient's pelvis. And this right here is the cecum. Let's make it even longer. This right here is the cecum. Remember, the appendix is going here and attaching to this iliopsoas muscle. This is becoming retroperitoneal. It gets covered with a layer of peritoneum. And then whenever you move this muscle, this causes pain. This causes you pain just because the appendix is inflamed. So when it moves behind the cecum and attaches to the iliopsoas muscle, this position is called retrocecal. Remember, the psoassign does not only indicate that the patient might have appendicitis, it also indicates the position of the appendix itself. That means that it's retrocecal. And this is frequently asked in vivas. I'll tell you what this is confused with by students. The obturator sign. Let's talk about the obturator sign. So in the obturator sign, you ask the patient to lie down on their back. You pick their right knee up. You ask them to make this whole leg flaccid. So what you do is, at the hip joint, you internally rotate. So what you do is basically this motion. Let's assume this is the patient's leg, and towards here, towards the screen, is their pelvis. So basically you rotate it inwards, you rotate it towards the pelvis, and you take their leg out. This is exactly what this demonstration shows you. You're rotating the hip joint towards the pelvis and the leg outwards. This is the obturator sign. And the patient will experience pain here. And why does that happen? Well, because this time the appendix has moved down into the pelvis, and attached to this obturator internus muscle. So the obturator sign tells you that the patient might have appendicitis, but also this time this appendix has moved into the pelvis. The psoas sign tells you that the patient is in the retrocecal position behind the cecum, attached to the iliopsoas muscle. The obturator sign tells you that this appendix has moved into the pelvis and attached to the obturator internus muscle. And only one of these can be positive. This is a frequently confused point. Only one of these can be positive at a time, because the appendix can only be attached to the iliopsoas muscle or or the obturator internus muscle in the pelvis. Either you're attached upwards retrocecally to the iliopsoas muscle or downwards into the pelvis to the obturator muscle. Thus, this appendix is located inside the pelvis, and that is obturatorsign. Now I'm going to also take this opportunity to also tell you that appendicitis is the most common presentation of acute abdomen in pregnant females, and it can present with pain anywhere in the abdomen. Why? Because the gravid uterus is pushing what the appendix or the colon in different positions. This could present with right upper quadrant pain or left upper quadrant pain. Therefore, you might have a very vague presentation of appendicitis in pregnant female. But remember, this is the most common cause of acute abdomen in pregnant females. Now let us talk about the diagnosis of acute appendicitis. So mostly this is a clinical diagnosis. This is a clinical diagnosis that is made mostly right there in the ER. Based on, you can have several supportive things like leukocytosis, meaning the WBC or the white blood cell count is high, and particularly you're getting neutrophilia. So you're getting neutrophilia, meaning you're getting a lot of neutrophils in the body. Why? Because you have active inflammation. Then you can also get electrolyte abnormalities because the patient might not be eating a lot, they might be vomiting as well. So you're getting electrolyte abnormalities. And on urinalysis, this is a frequently asked point in difficult examination. In urinalysis, you can get something called a sterile pyuria, meaning it's just WBCs and there's no bacteria, just WBCs in the urine. Why? Because the inflamed appendix can irritate the nearby lying ureters and cause WBCs in the urine, and that is a supportive thing. Now for imaging, our most and first important first line thing is going to be CT with contrast of abdomen and pelvis. This is going to be our first line imaging study for people with appendicitis. And for pregnant women and children, this is going to be ultrasound. And if ultrasound or CT, let's say in pregnant women and children, if ultrasound is inconclusive, you can go for MRI. Similarly, if CT with contrast is inconclusive, you can go for an MRI to further make the things more clear. Now before we look at a bad appendix, let's look at a normal appendix. So the first thing I want you to understand that the thickness of normal appendix is usually less than 6 millimeters. It's going to be less than 6 millimeters. What else? The thickness of the wall itself is even less than 3 millimeters. This is how a normal appendix should look. Remember, when you want to get something bad on a CT, when you want to understand if there is something bad on the CT, you should know how it looks normally. And remember, what view of a CT is this? This is an axial CT, meaning the person is lying down and you have cut through cross-sectionally, and this is how you're looking, and you're standing at the patient's foot end, and this is the left side and this is the right side. And now let us look at a CT of a person with appendicitis. Again, this is the left side and this is the right side. So now you can see this appendix, and this looks a lot bigger than 6 millimeters. If you have in the ER and on your hospital computers, you'll have a thing to measure this thickness, and I know for sure this is going to be more than 6 millimeters, and maybe even the wall is bigger than 3 millimeters. And this is usually used in the diagnosis of acute appendicitis. What else you can use for the diagnosis is whether we want to get the person on CT or not. Remember, in developed countries, for almost every single patient, we are now getting a contrast enhanced CT. This is the first line imaging. Everyone who walks through the door, you're suspecting the risk of appendicitis. And how you suspect, this is one of the tools you use to suspect the risk of appendicitis, whether you should get a contrast enhanced CT or not, this is one of the tools. And this is known as the Alvarado score. And for the purposes of your exam, it's actually good to know this. When you have migration of pain, I told you about the migration of pain, meaning earlier you're getting that sort of dull, vague sensation of pain around the umbilicus, the T10 dermatome. Now that pain has migrated to sharp pain in the right lower quadrant. If you have migration of the pain, you have M. And then anorexia, meaning the person does not want to eat. They don't want to eat basically because they have this active inflammation and fever and nausea and vomiting. So they have this feeling of anorexia, and you get another point. you have nausea, and then you have tenderness in the right lower quadrant, and this adds 2 points, and this adds 2 points to the total. Then you get rebound pain. Again, you push in, and then as soon as you leave, this causes the patient pain. And sometimes I can also tell you, let's assume this is the patient's left side and this is the patient's right side. There's a very particular kind of sign sometimes that is also elicited. Just for the sake of completeness, let me add it here. If you press the left side and as soon as you leave it, basically, and it causes the patient pain on the right side, this is one of another sign of appendicitis called the Rovsing sign. I'm just adding this here for the sake of completeness. Rovsing sign. So whenever you push the left side and you leave it and it causes rebound tenderness in the right side, this is called the Rovsing sign. This is one of the signs that helps in the diagnosis of appendicitis. Let's go back to our Alvarado score. If you have rebound pain, this adds 1 point, and then elevated temperature, 1 point. Leukocytosis, meaning you're getting increased WBCs, particularly neutrophilia, you get 2 points, and shift of white blood cell count to the left, meaning you're getting more younger neutrophils, so the body is generating a lot of younger neutrophils. And how do you interpret this? If the score is 0 to 3, appendix is unlikely. If it's more than 4, you want to get a CT right away. Let's talk about the management now. So now let us talk about the management of acute appendicitis. How do we go about it? As soon as this patient is wheeled into your emergency room, what do you want to do? You want to do your ABCDs, airway, breathing, circulation, disability, and then basically get 2 large bore IVs into this patient. Then IV fluid therapy. You want to start this patient on IV fluid therapy as soon as they enter your emergency. You want to start this patient on analgesia because they're having a lot of pain. You want to start this patient on analgesia. Then you want to get a general surgery consult. Why? Because this patient is presenting with an acute abdominal pain, also called acute abdomen. This is the presentation of acute abdomen. You want to get a general surgery consult. Why? Because this patient might need some sort of a procedure. You want to get this patient nil per oral. Again, this patient might need some sort of a procedure, and for whatever procedure, they want to be on nil per oral. If this patient is recurrent vomiting, you want to put an NG in. You want to put a nasogastric tube in because you want to decompress the stomach because you don't want them aspirating on some sort of content. Then you want to put them on IV antiemetics, PRN. If the patient is vomiting again and again, you want to put them on IV antiemetics. And this, you're going to do all of these steps for every acute abdomen presentation in your emergency. You want to do them for every patient that presents with acute abdomen. Now, for every patient with acute appendicitis, you want to start them on empirical antibiotic therapy. Everyone gets it. This antibiotic therapy should cover gram-negatives and anaerobes because these are the predominantly bugs that are present inside your gut. Therefore, you need to cover gram-negatives and anaerobes. What's the empiric antibiotic therapy? You want to start them on monotherapy. Basically, you can use monotherapy as well as dual therapy that includes cefuroxime per metronidazole. And for monotherapy, you can use ertapenem or moxifloxacin. This is the empiric antibiotic therapy for acute appendicitis, and everyone gets it. So at this point, there are two ways you could handle this. One is the operative management, meaning this patient goes into the OR, and the other is non-operative management. So who gets non-operative management? So operative management is the gold standard for managing patients with uncomplicated appendicitis. And what do they get? They get laparoscopic appendectomy within 24 hours of their admission. This right now is the gold standard. This is the first line treatment for anyone presenting with uncomplicated appendicitis. So what is uncomplicated and complicated appendicitis? Let's look at that. So when we call something uncomplicated or complicated, uncomplicated is basically plain old simple inflammation, just nothing. Basically, you just have inflammation of appendix. So what could be complicated appendicitis? And then what do you do with it? Well, that depends on the presentation. Let's look at complicated appendicitis. So you call appendicitis complicated when there is a stone inside the appendix, also called appendicolith, like this in this CT. Again, you're looking at this CT axial view from the patient's foot end. This is the left side, this is the right side. Here you see a stone. This is very white. Remember, what is white on a CT? Bone, high density things, calcified things like a stone are white. What is gray? Soft tissue is gray. Like this is gray here. And what is black? What is black? Usually fats are black. Fat is black. Like here, right here, like here, fat is black. This white thing right here is a stone. What else could be complicated appendicitis? What else could be complicating appendicitis? A tumor. There could be a tumor in the appendix. That is complicated appendicitis. There is a phlegmon. What is a phlegmon? We'll talk about phlegmon and abscess in a bit. There could be a perforation, meaning there was so much pressure inside the appendix building up. There was inflammation inside the appendix that it burst, that it perforated. It let out its content into the peritoneal cavity, into the abdomen. Then you have gangrene. Then you have gangrene or necrosis of the appendix itself. So for now, let us talk about the difference between phlegmon and abscess and what are both of these. So what is exactly a phlegmon or an abscess? So let's look at it. So a phlegmon is an ill-defined mass of soft tissue inflammation. It's an ill-defined mass of soft tissue inflammation. This is not a term that is specific to the appendix itself. You can have a peritonsillar phlegmon. You can have a phlegmon in your hands or your forearms. It's basically just an ill-defined mass of diffuse inflammation, as opposed to an abscess, which is a well-defined mass that is usually surrounded by some sort of a wall that causes it to be so well-defined. And there's no pus in a phlegmon, and the abscess is usually pus-filled. How does an abscess usually happen? It's usually due to perforation of the appendix itself. It's usually the perforation of the appendix itself. So it's usually intra-appendiceal. So you get this well-defined mass. And what is phlegmon? It's usually peri-appendiceal soft tissue inflammation. That's why there is a movement to change even the term of itself. So some people might even call it just the term peri-appendiceal inflammatory mass. And that is basically a phlegmon. It's an ill-defined mass that contains no pus, and it's soft tissue inflammation of the stuff that surrounds the appendix itself, or the peri-appendiceal inflammation. So how do you manage both phlegmon or abscess? You manage them both non-operatively. So this is where the complicated appendicitis management becomes non-operative management. You go for non-operative management for both a phlegmon or an abscess, and what do? You send the patient home with a lot of antibiotics, broad spectrum antibiotics, and you keep monitoring them. And sometimes when you examine a patient with phlegmon, you might feel that mass. Same goes for the abscess. You might feel that mass in the right lower quadrant where the appendix usually lies. If the appendix is greater than 4 centimeter, then you might have to drain it percutaneously with CT guided drainage. So for phlegmon or abscess, what do? You give them antibiotics, you try to wait it out from the initial presentation and then maybe take it out. If the abscess is greater than 4 centimeter, you drain it too. You drain the abscess with CT guided drainage percutaneously. And then there's a term called interval appendectomy. That's why I said maybe take it out. Sometimes there is some evidence that as soon as you give antibiotics and the phlegmon or the abscess has resolved, after 6 to 8 weeks of the initial appendicitis presentation, you want to take the appendix out. But nowadays, this is only reserved for people with recurrent appendicitis or those greater than 40-year-old with a lot of comorbids. You don't want to keep having these infections on and on again. That is usually in developed countries when we consider interval appendectomy. It's not usually done so often anymore. So for non-operative management, who else do you consider? People who are unfit for surgery. You go for non-operative management. Who else? People who don't want surgery. So there is now this new movement so that you can manage appendicitis with just broad spectrum antibiotics. People who don't want surgery, they can talk to their surgeon and the surgeon can just prescribe them antibiotics and maybe they can go home. But right now, the gold standard for acute uncomplicated appendicitis is just operative laparoscopic appendectomy within 24 hours. When do you do an emergent appendectomy? Again, we talked about the management for each stage, for each type of complicated appendicitis. If it's a stone, you do an appendectomy. If it's a tumor, you might have to do an appendectomy. If the tumor is very big, you might even have to take the whole right colon out. If the tumor is sometimes bigger than the usual size that is used is around 1 centimeter. If the tumor is bigger than 1 centimeter, you might have to take out the whole right side of the colon. So when do you do emergent appendectomy? You do emergent appendectomy within 8 hours and with IV antibiotics. Who do you do it for? People in whom the perforated appendix, the appendix is perforated, it has burst, letting out the inflammation inside the whole abdominal cavity. you're getting peritonitis, inflammation of the whole peritoneum. You're getting that rigid abdomen, and the patient is complaining with a lot of pain throughout the whole abdomen. You have this peritonitis presentation, and that is a surgical emergency. So you want to do it within 8 hours and with IV antibiotics. If the patient is going into septic shock, you want to operate emergently. And if there's evidence that this appendix is gangrenous, that there's necrosis happening, this might predispose us to septic shock and peritonitis. Therefore, you want to operate on this person immediately within 8 hours and with IV antibiotics. So what's the takeaway from this lecture? Appendicitis is inflammation of the vermiform appendix. Appendix is that vestigial organ that is attached to your colon. What's the pathophysiology? Obstruction due to some sort of fecalith or fecalith in older people, which is basically feces deposition, and then in peds, it's due to lymphoid hyperplasia, which causes the infection and buildup of inflammation. Symptoms include nausea, vomiting, and periumbilical pain. This is early due to the visceral peritoneum, and late is right lower quadrant pain. Then signs like psoassign, obturatorsign, and McBurney's point pain. Right lower quadrant specific tenderness. And then diagnosis is mainly clinical. CT with contrast is first line imaging in developed countries. You have to do this in developed countries. Management, you start with supportive management like IV fluids, analgesia, antiemetics, get the patient NPO, and get the general surgery consult, and start them on broad spectrum antibiotics. What broad spectrum antibiotics? Usually third generation cephalosporins plus metronidazole. This is the dual therapy. Supportive care includes NPO, IV fluids, IV analgesics, IV antiemetics, NG tube to decompress, and antibiotics, which covers gram negatives and anaerobes, like I said. Operative management is usually for acute uncomplicated appendicitis and appendicolith. If there is a stone, you take it out. If there's a tumor, if the tumor is big, if it's bigger than 1 centimeter, you might have to take the whole right colon out. And if it's less than 1 centimeter, just take the tumor out. Just take the appendix out. Emergent appendectomy for gangrene, peritonitis, and perforation. For all of these people, we do operative management. You do emergent appendectomy for people who have necrosis inside the appendix itself, peritonitis, or perforation. Non-operative management is reserved for people who are unfit for surgery, who have a phlegmon. What is phlegmon? That soft tissue, ill-defined mass of diffuse inflammation. That is a phlegmon. It's usually developed from periappendiceal tissue. What is abscess? Abscess, when usually when the appendix perforate and then it becomes a well-defined mass surrounded by a wall, that is an abscess, and people who don't want surgery. So now let's solve the practice question. A 26-year-old male is brought to the emergency department with a complaint of progressive right lower quadrant pain for the past hour. He says that the pain has progressed from dull, vague sensation around the umbilicus to a more specific location around the right lower quadrant of the abdomen. Temperature is high and pulse is high, and blood pressure is fine for someone with pain. What's the most appropriate next step in management? So let's talk about the most important things. We have progressive lower quadrant, right lower quadrant pain happening for the past hour, and then we have the migration of pain. So that's very specific for appendicitis, and we also have fever. So even if we just apply the Alvarado score off the top of our head, so this gets progressive right lower quadrant pain gets 2 points, the migration of pain gets 1 point, and then the patient also has fever, so this also get 1 point. So this is 4 or higher than 4. The patient should get a CT. What's the most important next step in management? Obtain an abdominal ultrasound. Well, no. Perform emergent appendectomy. Well, we are not sure because we don't know if there's perforation. We don't have symptoms of perforation, gangrene, peritonitis, or septic shock. So not this, not an abdominal ultrasound. Order a CT scan of the abdomen and pelvis, which is the correct option because the Alvarado score was more than 4, so you want to get a CT scan. Start broad spectrum IV antibiotics. Well, that is correct. And observe. Observe is not true because we want to get this patient into the OR within the next 24 hours. So we're not going to just observe. Administer IV fluids and pain management and then discharge. Well, that is not true because we want to manage for acute uncomplicated appendicitis. The gold standard is doing a laparoscopic appendectomy within the next 24 hours. So thank you so much for watching this video, and consistency is key.